a pasar la charla del doctor Francesco Pichi acerca de membrana neovascular inflamatoria y su tratamiento basado en la evidencia. Adelante, por favor.
Good morning, everyone. Sorry I can't be with you in person. I'm going to talk about evidence-based treatment algorithm of inflammatory choroidal neovascular membranes. These are my financial disclosure, but they're not relevant to this presentation. Now, uveitis is actually the third cause of choroidal neovascular membrane. They are mostly type 2 because we are talking about young patients and the adhesion between the RPE and the neurosensory retina makes it more likely to be a type 2 choroidal neovascular membrane. They can virtually complicate any type of uveitis. You can see on your right side a table of the most common entities that are complicated by CNVs. In most cases, we're talking about multifocal choroiditis or PIC, and they're mostly located at the posterior pole. Now, the treatment of inflammatory choroidal neovascular membranes, it's dual. You have uveitis, so you have an increase in inflammatory proteins, and at the same time, you have an increase in the VEGF that develops the inflammatory CNV. Now, before the anti-VEGF drug, the treatments were mostly intravitreal steroid with immunosuppression and sometimes the combination of PDT. Everything changed with the anti-VEGF era. Now, the first thing is not to stop the trigger, so the inflammation, and using systemic immunosuppression, and at the same time combine with stopping the VEGF effect with an anti-VEGF injection. Looking at the literature, there's not a standardized treatment for inflammatory choroidal neovascularization. What is commonly known is that inflammatory choroidal neovascularization, they don't require a lot of intravitreal injection, but there's no head-to-head comparison between different treatment algorithms, different medications, so there's still a lot of uncertainties. The only study that actually looked in a controlled way at ranibizumab, in this case in other causes of CNVs, in this case inflammatory CNVs, was the Minerva study. And what was shown is that starting with a ranibizumab injection instead of sham, of course, increased the number of letters gained at 1 month and in the end at 12 months. Now, the problem is anti-VEGF, we know that they're effective. The control of the underlying inflammation is very, very important. But there are so many different regimens to use anti-VEGF injection to control the disease. PRN, loading and PRN, loading and fix, loading and treat and extend. So the best anti-VEGF treatment regimen for inflammatory choroidal neovascularization is still to be determined. So I'm going to start by showing you this paper. This is a retrospective study that compared 2 regimens of intravitreal injection, PRN from the start versus loading plus PRN for the treatment of inflammatory CNV. The primary outcome we looked at were at 12 and 24 months. The secondary outcomes were the number of injections and the number of recurrences of inflammatory choroidal neovascularization. We included 6 referring centers, and each referring centers used their own guidelines, which were either 3 months of injection then PRN or PRN from the start. Now, these are the baseline characteristics of the 2 group, and you can see straight away that there's no statistical difference in terms of age, in terms of sex, and even in the baseline best-corrected visual acuity. Most of the patients were on immunosuppressive treatment. These are the underlying cause of uveitis. Now let's look at the results. This is on your left side, that's the best-corrected visual acuity in ETDRS letter over the 24 months. And you can see straight away that the dotted line, which is patients on PRN from the start, there doesn't have a difference with patients who got a loading dose and then PRN. Even the letter change over the 24 months doesn't have a big difference between the 2 groups. Now looking here, you can see the p-value is not statistically significant in terms of best corrected visual acuity gain and the delta at 12 months and 24 months between the loading and the PRN. So overall, there's no significant difference in best corrected visual acuity at 24 months between loading and PRN group. Let's look at the secondary outcomes, so the numbers of anti-VEGF injection at 12 and 24 months. Now, in the loading, you can see that at 12 months, there is a higher number of anti-VEGF injection compared to the PRN, which is expected, and the difference is persisting at 24 months. So the p-value is statistically significant, so there's a difference between the two. Basically, they got the loading patients got 2 more injection both at 12 and 2 more injection at 24 months. So the loading group received significantly more injection than the PRN group, both at 12 and 24 months. What about the other secondary outcomes? So the number of recurrences at 12 and 24 months. You can see straight away from the two graphs, the recurrences here and here, that there's no difference between the two groups. And here in the p-value is not statistically significant, so there's no difference at 12 months and 24 months in the number of recurrences between the loading dose and the PRN treatment regimen. So no statistical difference between the two. So limitations, of course, this is retrospective, not randomized. There's no standardized systemic treatment. So some patients we saw around 35% were on immunomodulatory treatment, but not standardized. There's no head-to-head comparison between different agents, and there was not a reading center. But in conclusion, anti-VEGF injections were very effective in the treatment of inflammatory choroidal neovascular membrane. The loading phase did not give any advantage in terms of outcome or number of recurrences. PRNIs received less injection than those included in the loading group. So PRN from the beginning seems to be the best anti-VEGF regimen for the treatment of the inflammatory choroidal neovascular membrane. What about associating treatment in inflammatory choroidal neovascular membrane? We saw from the beginning it's very, very important, and we looked at it in this particular paper. Here we looked at patients with multifocal choroiditis, and we evaluated the influence of immunomodulatory therapy or steroids from the start in patients who had an inflammatory choroidal neovascular membrane associated with the multifocal choroiditis. So we divided the patients in retrospectively in steroids from the start and as needed, and immunomodulatory from the start, and a 2 years follow-up. The final outcomes was the final visual acuity, the number of CNV reactivation, and the number of injection. Now this is the baseline characteristic. Again, no statistical difference between the systemic steroids as needed and systemic immunomodulatory group. You can see it here. What about the results? First of all, the best corrected visual acuity. The mean change in the mean best corrected visual acuity in logMAR was statistically different and higher in the immunomodulatory treatment group. And the change from baseline was higher in the immunomodulatory group, even if not statistically significant. We can see it in this graph. So at year 1, this is the letters gained. At year 1, at 0 at year 1, there's no difference between the two. But if we look at the red line, which is the patients on immunomodulatory therapy, at year 2, there is a statistical difference between patients who are immunosuppressed and patients who are on steroids PRN. This is the same for the delta, so the change from baseline. You can see at year 1, not a big difference, but at year 2, it starts to be statistically significant, the difference, if you are immunosuppressed or just on steroid as needed. What about the number of recurrences? You can see straight away from the P here that they're all statistically significant. So patients who were on immunomodulatory therapy received statistically less injection compared to patients who were on steroids PRN. And you can see it here. Again, number of injection per year. At year 1, not yet statistically significant, but at year 2, it did reach statistically significant with less injection in patients who were immunosuppressed. The Kaplan-Meier show it very, very well as well. So in conclusion, immunomodulatory therapy was associated with lower inflammatory choroidal neovascular reactivations, lower need for injection, and better visual acuity compared to steroids alone. Immunomodulatory therapy should be considered in all patients with multifocal choroiditis, especially those that have an iCNV, given the great positive impact on the anatomical outcome. And with this, I thank you for your attention.